Great. Good morning, everyone. Yeah, and thank you so much for the generous introduction, Christopher. So, I'm Lance Okeke, and I'm over at Duke, and had the privilege of being involved with the REPRIEVE study over the last 8 years, and I've had a few months now since its publication mid last year to um, really kind of process what these results mean and also the communications that have come out since then from the Department of Health and Human Services and what that means for clinical practice. So we're going to go into detail about the study itself and about the guidelines released that has come out since the study publication and how we can actually start to, in a case-based format, implement that into practice. So this should take 45 minutes. Hopefully I don't run over, but we'll begin. Of course, I have no relevant disclosures. Now, I think most people on the call are familiar with this risk calculator. This is the 10-year ACC-AHA risk calculator. This is a screenshot just from a anonymous patient, and it allows you to kind of use the pooled cohort estimate. So basically the model that was used to come up with this global kind of assessment of what the risk of cardiovascular disease is for an individual patient 10 years from the time you put this data in. This is based on trials of multiple patients, thousands of patients over years, and the cardiologists are really good about big trials, big numbers, and lots of power. And based on those data, they've come up with a really cool calculator, which we should be using in all our patients, quite frankly, over the age of 40, to calculate what their risk of 10-year ASCVD risk is. And I think is widely used in primary care and increasingly in HIV medicine circles as well. However, I think it's been known now for several years, over a decade at least, that what the parameters that go into the model of calculating risk for persons living with HIV or persons that aren't living with HIV are actually inadequate for persons living with HIV, in that there are aspects of cardiovascular disease risk in persons with HIV that are unique to persons with HIV. And those risk calculators, as well-meaning as they are, were not made with persons with HIV in mind and this unique pathophysiology of cardiovascular disease in persons with HIV in mind. And so this study from JAMA Cardiology from last year demonstrated that, in which they looked at multiple risk calculators, the most popular ones, DAD, which actually was supposed to be HIV-specific risk calculator, Framingham risk score, the pooled cohort estimates, which were actually the equations that were used to make the ACCHA calculator I just showed you, and the score one. And just to try, there's lots of numbers and stuff here, but I'll try to break it down as simple as possible, in that they tried to see how many people were expected in a 10-year period or 5-year period for each model to have a cardiovascular disease risk event in persons with HIV. This was again with persons with HIV. And these trials actually took persons with HIV and says, let's use these models that are out there that weren't made for folks with HIV, and let's see if they actually are accurate in predicting cardiovascular disease risk in persons with HIV. The bar on the left is the OE ratio, which means how many people did you observe with a cardiovascular disease risk, with a cardiovascular disease event, and how many people did you expect to have one based on what the equation told you? The top bar on the right is a graphical depiction of this. I'm a visual learner, so I think graphics are great. And the top bar says, the dark blue bar on each panel shows you how many were actually observed, so how many they saw in terms of numbers of cardiovascular disease events. The accompanying lighter blue bar under each one shows what was expected based on the equation that was tested in that context. So how many events did they expect? And you can see here, without going into all the details, that on almost every case, the bar on the top outpaces the bar on the bottom, which means they actually saw in every single risk calculator that was assessed a higher number of observed cases than expected. They saw more cases of cardiovascular disease risk in HIV, persons with HIV, than they expected, than the equation, the global pool actually expected them to see. meaning that in every single case, these risk calculators actually shortchanged and underestimated the number of people that would have cardiovascular disease event, did not perform as well in persons with HIV. And so the question is, why do these conventional risk calculators consistently underestimate cardiovascular disease risk? These data from JAMA Cardiology of multiple trials show that, if you want to, we should be using these risk calculators because they're the best thing we have. But we also know that these risk calculators fall short in terms of estimated cardiovascular disease risk in this population. So how can we do better, and how can we be more aggressive, making sure that persons with HIV actually benefit from all the available evidence-based interventions for cardiovascular disease risk reduction? And what is it about the pathophysiology that makes it hard to predict cardiovascular disease risk accurately in persons with HIV? And so I think I'm just going to go through this quickly, because I think most people know this already, that more than half of people with HIV in the US are age 50 or older. That cardiovascular disease is one of the leading causes of morbidity and mortality amongst persons with HIV, top 3 easily. Persons with HIV are 50 to 100% more likely to have a heart attack or a stroke than persons without HIV. And that depends on what study you look at, but I think there's clear consensus there that risk is elevated, even with achieving viral suppression. Risk factors, modifiable risk factors like smoking, hypertension, high cholesterol are as prevalent in persons with HIV, or at least as prevalent with persons with HIV as a general population. And traditional risk factors account for some, and many would argue most, but not all, of observed cardiovascular disease events in persons with HIV, as those graphs prior alluded to. And so I'm not going to go into this, but this is one of my favorite kind of complex slides to really kind of give us some summary of why we believe that cardiovascular disease is different, cardiovascular disease risk and pathophysiology is different in persons with HIV. What are the unique aspects of chronic HIV infection that give you, that elevate cardiovascular disease risk in this population? The blue bar, the blue panel all the way to the right of your screen is traditional ACV risk factors. We understand that, yes, people with HIV smoke, they have hypertension like everybody else, diabetes, and metabolic syndrome. We won't get into that. But it's all these other factors that are really unique to the population. The fact that because of depleted immunity within the gut mucosa, that there's increased likelihood of bacterial translocation. So small, low-grade, non-clinically significant transmission events of bacteria into your bloodstream that keep the vessels in your blood vessels activated and inflamed on a small, low level over time. In each of those small doses, that kind of adds up in terms of like accelerating what we call vascular inflammation. Of course, there are certain viruses that are more prevalent or more active in persons with HIV in the context of immunodeficiency, like CMV. We know CMV is, almost ubiquitous, and we know that when it's activated, however, so out of its latent phase, that it actually increases vascular inflammation, perhaps more than any virus that we know. And then we also know that there's chronic inflammation just from having HIV and the turnover of immune cells in this context of constant chronic viral suppression. And so, in that context, we always look for ways that we can actually be more aggressive, because none of these factors that I've told you about, whether it be chronic immune activation or bacterial translocation or whatever, are accounted for in those global risk factors, those risk scores that I presented to you, because those risk scores were not made with persons with HIV in mind. And so I don't get too much into the weeds of like the specific immune phenomena that are explain these kind of increases in chronic inflammation. However, I will say that, if you think of the fact that these T cells and monocytes and macrophages and all these different immune cells are constantly, or I would say more activated in the context of chronic HIV infection than someone not living with HIV. In that context, you can understand why vascular inflammation persists on a level that's not really recognized in persons not living with HIV. And so I think that just kind of sets the stage for why, because there's not a box on those global risk scores that says how much inflammation do you have in your vessels. then there'll always be a underperformance of those risk scores and persons living with HIV. So let's talk about statins a little bit. I think, you know, full disclosure, I'm on a statin. Like I've been on a statin for a long, long time, and tolerated really well, and I have no issues so far. And I think they're miracle drugs, quite frankly, in that the cardiologist will tell you if you talk to them that you should just have this stuff in the water. People should kind of move on along. And just a little bit um, about their mechanism of action. And so essentially, in a nutshell, what they do is they actually decrease the level of cholesterol in the liver cells. And by doing so, by blocking the pathway that makes cholesterol in liver cells, the process of cholesterol in liver cells, they actually allow this natural and really cool response of the body to actually put more cholesterol scavengers on the surface of cells, on the surface of these liver cells, so they can actually start to pull cholesterol out of the bloodstream and into the cell, because the cell is saying, I don't have enough cholesterol because this statin has blocked me from making it. Can you go out to the bloodstream and get more LDL cholesterol and get it out of the bloodstream so the cell can use it for whatever process it needs, basically. It's really an amazing mechanism. It's very, very elegant and simple, but it's highly effective. And over the course of time, it's shown to decrease cardiovascular-related mortality, these drugs, significantly, over 25 large cohort studies. There's no question about it that the only drug that has been shown consistently to reduce cardiovascular disease-related mortality in all kinds of populations are statins over the last 25 years. And so, but even interestingly, and they've done this also in persons with HIV and persons without HIV, they've actually shown that if you actually look at the blood vessels of people on statins over time, there's not just plaque stabilization in terms of the coronary disease plaque or the vascular plaque. In many cases, there actually is a reduction of the size of plaques in the blood vessels for people who have been on statins over time. Not just plaque stabilization, but in some cases, plaque reduction in size. So, you know, I think these are wonder drugs. And, you know, the question is, how do we kind of choose and select who are the right folks to actually get on these statins? And I think REPRIEVE went a long way in doing that. I'm clarifying that for persons with HIV. Now, one thing that's unique about statins that is probably less broadly known is the fact that, you know, they do have anti-inflammatory properties. That study after study has shown that persons in these randomized clinical trials of statins, after you kind of look at them over a period of time, they actually have lower levels of pro-inflammatory cytokines. So IL-1, IL-6, TNF alpha, and CRP across the board. Now, you know, the question always has been like, what is the mechanism for why we see these lower levels pre-post of persons not on statin and become on statin, and all of a sudden these pro-inflammatory markers go down? And that's still being elucidated to some degree, but the general mechanism is that, you know, in the context of vascular injury, so when there's kind of an initial event of the endothelium being injured, a large part of a plaque formation, of plaque forming that causes eventually cardiovascular disease events, when that plaque ruptures and blocks off one part of your blood vessel, a distal part of your blood vessel. A large part of that injury is what's the inflammatory response? How do the blood vessels, the blood cells and the immune system respond to that injury? And in many cases, they're helpful, but in many cases, there's harm in terms of like the level of inflammation that kind of hits that blood vessel lining. And so statins actually kind of calm down that inflammatory response so that the damage from those kind of like monocytes and macrophages coming in there and doing their thing is actually less than otherwise would be if there was no statin on board, basically. And so, you know, the mechanism is thought to be through this leukocyte migration process, inhibition of local MCP1 IL-6 chemokines. And so you don't have as many like white blood cells responding to these areas of vascular injury. And so not as robust plaque formation. So statins do that. And based on this hypothesis, numerous studies have come out actually to look at ways in which we can actually decrease inflammation and decrease this kind of inflammatory response, because the cardiologists knew that it wasn't just kind of lipids being high themselves and cholesterol being high, but there was actually an inflammatory immune component to atherosclerosis, to plaques being formed in the blood vessels. And so lots of studies in New England medicine over the last decade, canakinumab, which is IL-1 beta inhibitor, they use in some autoimmune conditions, methotrexate, colchicine, some of them work better than others. Canakinumab, the CANTOS trial worked, methotrexate was okay, colchicine kind of fell on its face. But the question was about rosuvastatin. So we're saying that statins have anti-inflammatory components. Can this anti-inflammatory component of statins be used to reduce cardiovascular disease events in persons in the general population? So this was a Jupiter study published in 2008. And what they did was they said, okay, well, we know statins reduce cholesterol levels, right? But if we were to look at a group of persons who didn't really need the statin for cholesterol lowering because their cholesterol levels were already low enough, would we still see benefit in that population? And if we saw that benefit from people who had LDLs less than 130, so really low, relatively low cholesterol levels anyway, if we gave those people statins, we still see a reduction in cardiovascular disease events, even though their cholesterol levels were low to start with. And if we saw that benefit, could we perhaps hypothesize that benefit, that added benefit, despite having a lower cholesterol level before you even started statin, was because of a reduction in inflammation? And so they looked at people with high HSRC, high sensitivity C-reactive protein, so a marker of inflammation, and relatively low cholesterol levels. So saying, okay, well, you have high inflammation for whatever reason, but your cholesterol is low. Let's give you a statin and see if we can actually see a change in cardiovascular outcomes. And what they found is that the trial was stopped early due to efficacy, in that in this group of people who had relatively low cholesterols and high levels of inflammation, they gave them a statin, rosuvastatin 20, so high dose, heavy duty statin. And they saw a 44% reduction in the primary endpoint, the composite endpoint of heart attack, stroke, cardiac revascularization. And they saw a 44% reduction in those events. And they saw a 54% reduction in myocardial infarction. They saw a 47% reduction for the group that got the statin over the group that didn't get the statin in cardiovascular disease-related death, in stroke, and in heart attacks, basically. And they saw a 20% reduction in all-cause mortality. So people who got the statin, in this group of people with high inflammation, low, relatively low LDL levels, they saw a 20% reduction in all-cause mortality. So death from any reason, 20% reduction. And that was statistically significant. They also saw, again, trying to hone down on this hypothesis of inflammation as a cause, a 37% reduction in high sensitivity CRP levels. So basically that reduction in inflammatory markers, they saw that as well. So, this was the rationale behind the REPRIEVE study, in that if we're saying that inflammation is probably a larger part of cardiovascular disease in persons with HIV than the general population, will statins uniquely decrease the risk of cardiovascular disease in persons with HIV because of the high inflammatory component, because of the attributable risk of inflammation and cardiovascular disease in this population? And so, we talked about all this already, but the hypothesis was the same as Jupiter, in that if we give statins to people who don't need it for lipid lowering based on current guidelines, will we still see a reduction in cardiovascular disease events? And if we see that reduction, can it be attributed to statin-induced reduction of vascular inflammation, the inflammatory process? And so this was this trial design for REPRIEVE. We started enrollment here in April of 2015. But the basic study question, again, was, does statin use reduce ASCVD events in persons with HIV who are at low to moderate risk for ASCVD based on global risk calculators? And so the goal was to get people lower on the ASCVD risk scale who by guidelines didn't really need a statin. Now, of course, for folks who have followed the study closely, because of concern of reaching enough outcomes with people with very, very, very low risk ASCVD, enough outcomes in the control arm and the intervention arm, those criteria were changed over the course of the study. And you can talk about methodologically how that holds, but the point is that they had to kind of broaden out the cohort in many ways, I'm glad that they did, because it kind of gave unique insights that we'll discuss in terms of the results today. But basically, they actually took folks, 3,700, about 3,700 on each arm, to randomize them to either pitavastatin, so the a statin 4 milligrams daily, or placebo, so essentially sugar pill. And they said these are folks that we know by ASCVD risk guidelines don't need the statin, but we assume that they all have high inflammation levels, like in Jupiter, because they're living with HIV. And let's follow them for a long time, 5 to 8 years, and let's see if we can actually reduce cardiovascular disease events in this population. You see the inclusion and criteria, exclusion criteria there. But this was a very old schematic when we were trying to kind of advertise this trial to folks around the triangle. This old school schematic of what we did. We know that the things have changed differently from this, but it's really elegant in that it shows in graphical form what they were trying to do. The main outcome being that combined clinical primary endpoint of cardiovascular disease, myocardial infarction, unstable angina, stroke, or any coronary revascularization. And the secondary endpoints you can read below. But two key points were the site investigators could stop the study drug at any point, so they could stop statin and say, hey, my person has reached a certain level of risk, I'm going to start them on a statin anyway, right? And that happened a lot. It happened in our clinic. I remember that happened a couple of times. We had these conversations where it's like, well, they may be receiving statin through your trial already, but you don't have to unblind them. Well, you have to, I'm going to give them the statin, so you may want to unblind them so we can go ahead and start them on the real statin, basically. But the analysis was done with that intention to treat, which means if we started you on statin on day one, regardless of what your doctor did after the fact, you were analyzed in that intent to treat arm. And that's how the analysis was done, because we actually started you on statin. So whatever happens after the fact doesn't really matter. The intention was to put you on statin, and so you remain in that statin arm for analysis, for analytical purposes. And so we talked about the primary and secondary outcomes, and we'll jump into the results of the trial. So this is one of the largest trials in the history of HIV medicine, definitely one of the largest drug trials in HIV. 10,865 participants enrolled, over 160 sites across the world. And ultimately, so it's 10,000 screened and 7,769 enrolled. Of those, 6,452 remained in follow-up. And you can see the numbers for the pitavastatin and placebo groups. There was very little treatment discontinuation because of adverse events, 2.1% in the pitavastatin arm and 1.2% in the placebo arm. And like we talked about, many people were initiated on a statin because of physician preference, clinician preference over the course of the study. So that number was 223, and people on the pitavastatin arm, 5.7%, and 9.6% of all the participants in the placebo arm. So it's interesting because you kind of expect that, because if the cholesterols were low anyway on the pitavastatin arm, then it was less likely that their provider would actually start them on a statin on their own. And so that those numbers hold. It is striking that despite being on a statin for many years in the pitavastatin arm, that providers still chose to start statins a lot of these folks anyway, and that's up to 6% of the patients in that arm. So just to kind of break it down, the population, median age was 50 years old, 65% non-white, 31% female sex at birth. And the median LDL, I think, is key. It was 108. So it was actually relatively low. They actually hit their goal of trying to get to a group that was of relatively low LDL, meaning that for most people walking around with LDL of a bad cholesterol of 108, a lot of those people wouldn't be started on statins. And so I think they achieved their goal in that way. And the ASCVD risk score was actually better than I expected, in that the median was still under 5%, so 4.5. So many of these folks should not have been on statin based on what the guidelines were at the time. And they were on statin anyway, and we'll see if it benefits this group. 88% of them were suppressed at baseline, and that's the median CD4 count of 621. Now, the median follow-up time for each of them, so how long they were followed over time, was on average 5.1 years, and 73% of them were on treatment at study end. We talked about the adverse event rates in both arms, 2.1% in the pitavastatin arm, 1.2% in the placebo arm. And then we talked about the clinician statin initiation rates, higher in the placebo arm as you would expect. So closer to 10% in the placebo arm, right under 6% in the statin in the pitavastatin arm. And then we get to the primary outcome reporting and the results. So, the combined outcome of major cardiovascular events, any arterial revascularization, having a heart attack, having a stable angina, having a stroke. In the pitavastatin arm, amongst 3,800 persons in that arm, there were 89 cardiovascular events compared to 136 in the placebo arm. So numerically, clearly less in the as folks randomized to pitavastatin. When you look at follow-up years, so really kind of normalizing for how long you followed up each observation within each arm. 4.8 events per 1,000 person years of follow-up in the pitavastatin arm, 7.3 events per 1,000 person years in the placebo arm. That hazard ratio for the incident rate ratio was 0.65 and met statistical significance. So a 35% reduction in new cardiovascular disease events in the pitavastatin arm compared to the placebo arm. Looking at the combined outcome of first cardiovascular event or death, same thing here. 9.1% of the pitavastatin arm, 11.6% in the placebo arm. That was 21% reduction. So hazard ratio 0.79. That met statistical significance as well. And so, when we do start doing the subset analysis, the same things, if you look at first cardiovascular events, so looking at the top of this plot, and all the things, basically in every case in the primary outcome, there was and again, thinking of the population, people who did not have particularly high cholesterols, but were living with HIV as that kind of chronic inflammatory state, there was a favor of the statin group. Of course, in terms of just death by any cause, there was no difference between the groups, but death due to cardiovascular diseases were definitely decreased in this population. And so I'm going to skip ahead of a lot of this, but I want to kind of focus on this slide here, which shows the fact that if you subset out who benefited the most amongst the study population by ASCVD risk score, it was actually the group between 5% and 10%, 10-year ASCVD risk score. The greater than 10% group showed no benefit, but there were relatively few of those, and a bunch of those people probably got started on statins by the provider anyway, and so it kind of balanced out the outcome. So, but the 2.5 to 5% group is an interesting one, because the question becomes, do we have enough evidence to justify starting statins on people less than 5%, with a less than 5% 10-year ASCVD risk score? And so, if you actually look at the ASCVD guidelines from the AHA from 2018, so the most recent ACCHE guidelines on blood management of blood cholesterol, they say that people with an intermediate risk classified as a 10-year risk score of 7.5 to 20%, essentially, should have statins considered, and they favor initiating statin therapy. So if you're 7.5%, then that's fine. But is a group lower than that? Because REPRIEVE is looking at 5% to 10%. So what happens to the people between 5% and 7.5%? And the data on REPRIEVE were based on people from 5 to 10% and showed benefit all the way down to 5%. Now, they acknowledged 5 years or 6 years before, 5 years before REPRIEVE was published, that persons with chronic inflammatory disorders, including chronic HIV, is highlighted in this slide, were considered people with a risk enhancement factor. And people with risk enhancement factors may favor statin therapy at 10-year risk of 5 to 7.5%. So in many ways, there was some kind of foreshadowing here by the way these guidelines and ACCHA were written, that perhaps people with HIV as low as 5% could benefit from statin use. But then this recommendation came out after the release of REPRIEVE, with many of the REPRIEVE investigators on it. This was from February 27th of this year, so just a short 2 months ago. Trying to kind of help people disentangle what this meant in terms of REPRIEVE. And so, of course, based on REPRIEVE data, anyone with the ASCVD 10-year risk score between 5% and 20%, the panel strongly recommended initiating of at least a moderate intensity statin. You can see the level of evidence here. So if you're anyone, ASCV would score between 5% and 20%. So that's including that group of 5 to 7.5% that wasn't accounted for in the broader guidelines. Anyone with the ASCV 10-way risk score of down to 5%, you give them a statin. The class A1 indication, you just do it. Of course, they also recommended that persons less than age 40, there was insufficient evidence to recommend for or against statin use. So this really is focusing on people age 40 and above. 5% ASCV risk score or higher, give them a statin. But the panel also said this, which was actually pretty interesting, kind of leads us to our last few slides, that they were in favor of at least a moderate intensity statin for people with ASCV risk scores of less than 5%. And I just showed you the data from REPRIEVE that showed that 2.5% to 5%, there was really not much benefit at all. But you know, they recommended that you actually give a moderate intensity statin to people of less than 5%. But this should be based on shared decision making to initiate a statin, accounting for the presence or absence of HIV-related factors that can increase ASCVD risk. So understanding that that group was probably very heterogeneous, and that the risk calculators, as we talked about at the beginning of my talk, oftentimes underestimate true risk. And so in terms of risk quantification, it's really tenuous to say, hey, 5%, less than 5%, no statin, over 5%, no statin, because you really don't know all the parameters go into an individual's risk of cardiovascular disease, especially if they're living with HIV. And so I think that's really key to say, that we really have to be careful of saying that, hey, the evidence didn't say anything less than 5%. The evidence didn't prove that less than 5% benefits from statin, so why are we starting them on it? I think being thoughtful and approaching everyone on a case-by-case basis is essentially the spirit of how these guidelines were written. How I kind of look at it is like, you know, I look at persons with prolonged duration of HIV. And so if my patient has had HIV for 20, 25, 30 years or whatever, then for that person, even if their ASCV is less than 5% and they're 40 years or older, I actually start them on a statin pretty routinely. There are exceptions, and we'll talk about that in a second. If they had a low CD4 nadir, if they had a delayed antiretroviral therapy initiation, so long periods of unchecked viremia, basically because they weren't on antiretroviral therapy. Their exposure to any of the older antiretroviral drugs, and of course, co-infection with hepatitis C. And the guidelines corroborate this approach. And of course, this is not comprehensive. There are individual factors in each patient that you should kind of assess on your own. The guidelines are guidelines, and essentially you're the patient's clinician, and only you can kind of make that non-textbook call of who should be on the statin and who should not be. And so I'm going to start with a couple of cases just kind of to demonstrate this to close. And looking at this 45-year-old Black cisgender woman who has been diagnosed with HIV, was diagnosed with HIV in 2012, and it's been suppressed for the last 10 years continuously. She's never smoked. She has no history of diabetes, but she's over the age of 40, so she's 45 years old. And she is on hydrochlorothiazide daily for the last 2 years. She comes into your office today with a blood pressure of 129/72 and asks you, doc, you know, I've been hearing about this statin stuff and REPRIEVE stuff. Should I be on it? Her cholesterol, as you can see right there, she has a decent HDL, and the LDL doesn't look too terrible at all. It's 88, so that's actually pretty great. Her 10-year ASCV risk score is 2.7%, so well under 5. The question is, do I start this person on a statin? And I would actually say this is the rare exception of the person over the age of 45 who I would actually consider deferring a little bit, because of course statins, like any drugs, have their own side effects. And to me, her risk score is so low, she has very few risk factors, and relatively recent HIV diagnosis, has been on a blood pressure med and is well controlled, never diabetes, never smoked. I think we can wait a few years on this one. And I know there's not consensus here, but for me, I would wait a little bit here. The second case is more interesting because this person is now 3 years younger, was diagnosed relatively recently as well in 2017, and she smokes a quarter pack of cigarettes a day. She has no history of diabetes, but she's also on hydrochlorothiazide for blood pressure. And you know, with that smoking risk, you can see where her numbers are. Her BMI is 27, so not particularly not obese, and her cholesterol is the same as the last one, but she smokes a quarter pack a day, and her ASCV risk is still under the 5% threshold. Now the question is, like, why why would I start this lady on a statin and the last one I would not? And the reason is simple for me, in that I would actually start this woman on a statin. And the reason why is because she smokes. She smokes, and we know that the attributable risk of cardiovascular disease due to smoking in persons with HIV actually is disproportionately higher in persons with HIV than persons without HIV. Smoking is more causes more damage to the vessels of people living with HIV than without, because of that kind of synergy with chronic inflammation. And her trajectory for her 10-year risk in the next couple of years crossing that 5% threshold is much higher because she smokes. So by the time she's 44, she'll cross that 5% threshold anyway. So getting ahead of it by 2 years and starting her on a statin right now is probably not the wrong thing to do. You've given her those extra 2 years of benefit, and so you kind of go from there. But she's close, and she's going to cross 5 in a couple of years. And so I start her on a statin even though she's less than 5%. Here, you have a 55-year-old Black cisgender man who is diagnosed back in 1997. He's a picture of health, doesn't use tobacco, doesn't use no history of diabetes, no history of hypertension, works out 4 days a week. And this is the one I kind of struggle with the most, but I tend to be more aggressive in this than most. And so I think for him, even though his ASCVD risk score is 4.8%, right? And he's a picture of health and has gone this long into his life with the ASCVD risk score this low, I would actually kind of talk to him closely about it to see if he would consider it, and probably would kind of nudge a little bit, say, hey, like, you've gotten this far doing all the things. And so what's if this one med can actually give you even if you can benefit even in a small way from cardiovascular disease related risk, then why not? But if he said no, like, I'm good, doc, I'll try to stay away from all those meds and everything, then I'll be like, all right, well, let's keep on talking about it. But here, I would actually kind of like really kind of lean into that shared decision making and say like, hey, what do you want to do, sir? But you should know that the data are available. And if you want to start, I'm here for it. I would do it, but I can understand why you wouldn't want to do it. So in this case, I think this is where I'm on the fence a little bit, but I would actually lean towards starting with the ear to the patient in terms of like how they want to proceed going forward. And the last case from here, 46-year-old white man, HIV diagnosed in 2013, quit smoking 3 years ago. His blood pressure is elevated, not on blood pressure medications. His BMI is 32. His LDL is in the 120s, and his ASCVD risk score, surprisingly, is only 4. For me, this is an easy decision in that there's lots of little red flags here that are kind of like recent smoker, blood pressure elevated, he's a little obese, his LDL is probably higher than I would like for it to be. Even though his ASCVD risk score is 4% based on these parameters, I absolutely start this man on a statin. And so the take-home points in closing are, the fact that it should be known that the burden of ASCVD risk in persons is increasing, and there are fundamental differences in the pathophysiology of ASCVD in this population than people not living with HIV. Statins are the first drug class to demonstrate a decrease in CVD-related mortality in persons with HIV. REPRIEVE has proven that in cardiovascular disease-related mortality, statins do decrease that outcome. And based on the results of REPRIEVE, the current guidance recommends statin initiation in all persons with HIV over the age of 40, with the ASCVD 10-year risk score greater than 5%. So if it's over 5% over the age of 40, you start it. It's evidence-based. You don't even think about it. But in persons with HIV with less than 5%, the guidelines as they read but from DHHS right now are that all persons should be considered regardless of ASCVD risk score if they're living with HIV and if they're over the age of 40. I would say, those are based on class C1 evidence, meaning it's mostly expert opinion. And so in that, there's always latitude for you to kind of really consider your patient's case and say like, hey, based on the person I'm treating, based on their but their particular situation, is the statin initiation right for them? I gave you 4 cases all simulated about how nuanced these decisions are, but you really should kind of at least consider it on a case-by-case basis and see where you think things should go. And then, of course, most of all, HIV is a risk enhancement factor, so consider that. And because of that, check ASCVD risk global scores on all of your patients over the age of 40, period. Just do it. You have a number there, and because you can't make any of these decisions without having some idea of what their global HIV ASCVD risk is. And so check them out, make calculators that are installed in your EHR, utilize those. If you need to kind of go back and forth to the page, you know where it is. But definitely all patients should have an ASCVD risk score calculation the moment they cross age 40, especially if they're living with HIV. So I'll stop there for questions. I'll stop sharing.
All right, great. Lance, thank you so much. So we have one question in the Q&A, and if other folks have questions, please feel free to drop them in the Q&A or the chat. The first question was from an anonymous attendee who asked, would insurance cover statins if the client does not meet the minimal requirements?
Yeah, so the answer is increasingly yes. You can make that case. And so of course for HMAP and all that, it's part of the formulary. So that's not fine. That's fine. But yes, the answer is yes.
Okay. Second question from my colleague at UNC, Dr. King. Good morning, Louise. Do you prescribe pitavastatin preferentially over the other statins?
That's a great question. So the answer is, for me to that is actually no. I don't prescribe much pitavastatin at all. I mean, I understand that people kind of interpret the data as saying, hey, atorvastatin wasn't studied here, rosuvastatin wasn't studied here. It was pitavastatin. To me, they're all the same. My go-to is atorvastatin 20 milligrams QHS. And so, but I mean, everyone has their own choices. Some people use Rosuva at 10 milligrams. People use what? I don't think the type of statin matters, quite frankly, but that's just my opinion.
Yeah, and so, Lance, do you think that, so pitavastatin, I think, is still brand name, heading to generic very shortly. Do you think that's going to make any impact, or do you think we should be like adhering to REPRIEVE, or is it 601 half dozen the other?
Yeah, to me is the latter. It's like, I mean, some people will try to stick to the interpretation of REPRIEVE as literally as possible, even when it goes when it goes generic. For me, like, I mean, I don't feel like we need another clinical trial to say that atorvastatin actually does the same thing that pitavastatin did in REPRIEVE. So that's my interpretation of the data.
Okay, that's good because that's what I've been doing. Another question from Veronica Ray. Are you trying to reach a goal of less than 70, which I'm assuming is maybe the LDL level?
Yes. So I mean, I think if you talk to cardiologists, they'll just tell you, no, the LDL related goals are fine, but the goal is as low as possible as you can get it, basically. And so just start it, titrate it up, and get that LDL as low as possible. And that's kind of been my approach. So of course you check lipid panel periodically just to kind of see where things are, but it's not with kind of like a hard and fast kind of like grasp of like it has to be 70 or else I have to like put them on Repatha or something like that. So
okay. And then one last question. So Babafemi Onabanjo asks, any alternatives if statins are not tolerated at all by the patient?
yeah, so the quick answer is like no good alternatives. And so there's nothing really that can replace statins in this regard. I mean, you won't get PCSK9s unless you try a statin. You can mess around with the bile acid sequestrants and Zetia and all that. None of them actually really kind of have the evidence base that statins do. I think we all kind of know that, but I mean, I think it's worth saying. So now, of course, there are tricks in terms of like how you dose statins, like every other day dosing or weekly dosing or whatever. But if you can get even just a little bit on board, and actually I've had many cases where the every other day dosing of atorvastatin actually works pretty well for some patients. If they can remember and they're disciplined, then you can kind of do that. But I mean, I think in terms of like a true like for like evidence replacement for statins, there really is none. And so
All right, Lance, thank you so much.